Thank you very much, Andrea. This city holds a very special place in my heart for a variety of reasons. One, I learned that my goal in life to become a radiologist actually got started here, and it was because of a lot of the people who were staff people at Victoria Hospital when I was an intern. And secondly, I met my wife here in London, Ontario. And again, a very proud and happy moment for me. Now, this evening, I'm going to talk to you about some pediatric radiographic findings that you don't want to miss. And the objectives of this talk are to learn some important imaging findings for common pediatric clinical presentations. And I'm going to do this using a case-based interactive format. So those of you who have Socrative, it would be a good chance for you to turn it on, and we'll give you some feedback on it. And my other second objective of this talk is to be able to improve your interpretation skills of both chest, abdominal, as well as musculoskeletal plane radiographs. And my hope is that this will be something that you can utilize both in a clinical practice within clinics, but also in the emergency department as you interact with children from an imaging point of view. In terms of disclosure, I received grant support from Bayer Incorporated, but I'm not going to be talking about any of the products that they put forward. So if you sign in, this is the room number to sign in on. I'll give you a, I think it's 0D830C2C. I'd also like to thank Matt for shuffling me around today, but also more importantly, teaching me how to use this program. So this, I'm quite interested to see how this works out, because I think it was very neat. I tried it with my kids this weekend. So
enter my name. I don't want my name because I don't know.
Okay. Did that work for everyone?
Yes.
Okay. So what I'm going to do is show you a bunch of cases and then give you some choices as to what the various options are. And then we'll go over an explanation of how we got to the findings that we've gotten to. Okay, so let's start. So the first case is a 5-month-old who is a previously healthy term boy and basically presented with a 1-day history of cough that had worsened over the past 24 hours to their pediatrician. The child didn't have any fever, there were some wheezes on examination, and the child was felt to have a little bit of labored breathing, and the child was sent for a chest x-ray. So here's the radiographs, a PA and lateral. We have choices here of cardiomegaly, left lower lobe pneumonia, mediastinal mass, or a normal exam. So what do you think? Okay, so I've got answers for most people, and the most common response that I got back was cardiomegaly. So if we look at this chest x-ray, there's a couple of interesting things. The mediastinum looks enlarged. It looks prominent, it looks wide. But if we look on the left border of the mediastinum, we can see that there's an undulated pattern to that heart border. And it corresponds to where the ribs are. And this is what's known as the wave sign. And what this is where the thymus, which is a very soft, pliable structure, where it interacts with the ribs will indent into it. And this is not a finding that you would see in a mass, and it's also not a finding that you would see in cardiomegaly. So this represents a normal anterior mediastinum containing thymic tissue. And the other correlate of this is what's known as the sail sign, which is where the inferior margin of the thymus indents against the minor fissure, and you can get what looks like a sail. Now this is a much more exaggerated version of this, and you can see the undulation everywhere that an anterior margin of the rib indents. So when you're looking at some child who's got an enlarged cardiomediastinal silhouette, look to see if you can see that notching on one of its borders. If you can see it, you can feel very confident that what you're dealing with is thymic tissue and that this is normal tissue. Now, in some places, especially in adults, you use what's called a cardiothoracic ratio. Well, that ratio actually has no value in pediatrics. There's such variation in the thymus, it can extend anywhere from the thoracic inlet all the way to the diaphragm. And therefore, that's really not a valid way of looking at radiographs. So this is, and this is a common thing. The sail configuration is actually seen in about 9% of healthy children. It's much more common on the right side. And it's not really seen on the left side because the undersurface of the thymus lies against and blends to the heart. So you don't really see that inferior margin that you would see on the right side. The wave sign, on the other hand, can be seen on either side. Okay, so let's look at the next case. The next case is a previously healthy 6-year-old girl. She presents with 6 days of upper respiratory symptoms, predominantly composed of a sore throat, difficulty swallowing, and odynophagia. She's had decreased oral intake, she's lethargic, and the next day she shows up with stridor and increased work of breathing. She has a soft tissue radiograph of the neck. And so is this normal? Does she have tracheitis? Does she have epiglottitis? Or does she have croup? So I'll just move to the next. Okay, so vote now. So the most common answer given was epiglottitis. And if you look at these radiographs, you can see pointed with a long arrow the epiglottis. It looks round, it looks bulbous, it's enlarged. But also notice the soft tissues that extend from the tip of the epiglottis to the arytenoids, also known as the aryepiglottic folds. They're also thick, swollen, and enlarged. And the thing to remember in this disease is that epiglottitis is a diffuse inflammatory process. It involves both the epiglottis and the aryepiglottic folds. And so here there are 2 examples, both of which show thickening of the epiglottis in the long arrow, and short, thick arrowheads point to the thickening of the aryepiglottic folds. And you can see this in this image taken from a laryngoscopic examination where, again, you can see the thickened epiglottis, but you can see the aryepiglottic fold swollen as well, extending from the lateral margins of the epiglottis to the region of the arytenoids. You can also see in the bottom right-hand corner what normal looks like. The epiglottis is normally a thin sliver of structures, and the aryepiglottic folds are also very tiny and thin. And so when you're looking at a case of questionable epiglottitis, and you're wondering if the epiglottis is enlarged, cast your eyes at the aryepiglottic folds. If they're swollen as well, that child has epiglottitis. And again, it's not an inflammatory process of the epiglottis alone, and look for that diffuse swelling. Here's another example of diffuse swelling of that epiglottitis, as well as the image that you can see at laryngoscopy. So the next case is a 16-year-old previously healthy boy, and he complains of throat pain. He says he feels like he's swallowed a golf ball. That's how much discomfort he's feeling. He's also got chest pain and epigastric pain. And the only thing of note is that a month ago he was wrestling with a friend. But other than that, he's had no history of trauma and no other complaints of any kind. So these are the radiographs that were obtained at that time. And their options are the child has a foreign body, there's a fracture present, there's an air leak, or the child has pneumonia. So a 16-year-old with throat pain. Okay, wait for one more vote. Perfect. Okay. So the most common answer was air leak. And if we look at these radiographs, if you look in the supraclavicular region, there are 2 paired lucencies that extend up into the soft tissues of the neck on either side of the trachea. And this was the esophagram done, which showed a wisp of contrast coming out of the ventral surface of the esophagus. So this patient actually has an esophageal tear, and that's what's producing this pneumomediastinum. Now, air leaks can be sometimes quite subtle to see on chest radiographs. On occasion, you can see sharpening in the margin of the mediastinum with pneumomediastinums. But in children, the passageway from the mediastinum into the neck is very open, and therefore it's very easy for air to track into the neck. So cast your eyes into that area. You can also see air within the mediastinum on a lateral radiograph, as pointed out by these arrows. And it's interesting to note that gas within pediatric mediastinums can spread very quickly. So take a look at this radiograph, and then look at this child 20 hours later. And so that's how much air can actually leak out in a very short period of time. Here again, you can see the elevation of the thymic tissue away from the heart due to gas within the mediastinum, as well as the extensive subcutaneous emphysema that's tracked into this child. And you know, the first radiograph was actually something that was missed. The child came back in 20 hours later looking like this. Okay, so the pearl for this case is to look beyond the thorax when you're looking for gas. You know, gas in the mediastinum, when we see it, can occur either from airways, and we typically can see these in children who are asthmatic, who can develop pneumomediastinums, but also we can see it from gas from esophageal perforations. And it doesn't take very much for children to have injuries to their esophagus and present in a very mild fashion. Okay, so our next case is a previously healthy 10-year-old who had a 2-week history of intermittent epigastric abdominal pain that he felt was 7 out of 10 in terms of discomfort. The pain was worse after meals. He didn't have any nausea, vomiting, or diarrhea, and his CBC, lights, bilirubin, liver enzymes, and lipase were all normal. And he came in and had this abdominal radiograph. Now this one's not a quiz case, but I'll just let you look at it for a few minutes. And you know, the bowel looks relatively normal. This was a case that actually was missed. But if you look at this, just underneath that right rib margin, there's 2 little calcifications. And these are gallstones. And we can see gallstones in children, and it can be a cause of abdominal pain, as you know from your adult experience. And so you should look for calcifications. I mean, they can occur just about anywhere. And you know, chronic pancreatitis we'll see in children. We'll also see ureteric calculi. But the one that I really want you to look for is appendicitis. Appendiculitis are actually relatively common in pediatric appendicitis, number one. And number two, they're very easily missed. And the reason they're missed is because they often overlie the sacrum and the sacroiliac joint, and it's very difficult to perceive them. And I think part of it is just the mental checklist that if you have a child with abdominal pain, to realize that appendicitis is very common, and you have to take and focus your attention in this 2 square inch area around the right lower quadrant to look for appendiculitis. It's a very common thing that's there, and it's also a very common thing that's missed. I can tell you that in the cases that get referred into us, at least once a month there's a kid with appendicitis where the appendiculitis are there and it's just not seen. You can see them also in ovarian tumors. This is calcification in a tooth in a child with a dermoid. Okay. The next case is a previously healthy 8-month-old boy. They have a 3-day history of breathing issues that are described as being wheezy, mild cough, fever, elevated white count. The child had been treated with dexamethasone and Atrovent with the thought that this child may have a viral lower respiratory tract infection or perhaps asthma, and there had been some improvement. The child had some worsening symptoms overnight, and on exam, the child's got indrawing, but also has inspiratory stridor and wheezing. So here's the chest radiograph. Does the child have a mediastinal mass, right upper lobe pneumonia, right upper lobe collapse, or a pulmonary mass? So this is one you can vote on.
Do you stop imaging or do you continue to something else?
If they've got right lower quadrant, they'll get to see a surgeon. and we'll stop. We actually, as I was telling the residents, we rarely CT children, and ultrasound we use quite freely. And so if we see an appendiclith and their story is good, the surgeons will just take them to the OR.
Without an ultrasound.
Without an
Sorry,
ultrasound.
That was kind of what
Yeah.
I was trying to
Yeah,
ascertain.
so they'll do that. Okay, so let's see. So the most common response was mediastinal mass, and that is correct. So if we look at this, the key finding here is the presence of rib changes. And here, if you look at this, you can see that there's indistinctness and erosion of the undersurface of the right third rib. There's a little bit of scalloping of the undersurface of the right fourth rib. And this, if you also look, the trachea is deviated to the left, indicating a mass. And the presence of that changes posteriorly is a real pearl. If you can find that rib change, that'll indicate to you that there's chest wall involvement, and it must be posterior mediastinal. And in children, the most common cause of a posterior mediastinal mass is neuroblastoma. And I have a whole collection of chest radiographs of neuroblastoma of the thorax that have been admitted to the ward as pneumonia because the rib changes are just not perceived. And so when you're looking at what looks like a relatively straightforward case, just cast your eyes at the ribs and just take a look to see, because if you can see it, you can actually come up with some really good findings. Here's another example. This is a newborn with respiratory distress, and they were thought to have a congenital pulmonary airway malformation. But if you look again, you can see that there's some splaying apart of the right second and third ribs. There's some scalloping along the undersurface of the right second rib, and this is a neuroblastoma. Okay, so here's another case. This is case 6. This is a 7-day-old girl with a history of hypotonia who had failure to thrive. She'd previously been on nasogastric feeds, and she now comes in with a 3-day history of cough, fever, wheeze, and decreased oral intake. And here's her chest radiographs. Does she have pneumonia? Does she have a vascular anomaly? Does she have a mediastinal tumor, or does she have tuberculosis? So this is another one you can vote on. Okay. So if we look at this PA and lateral radiograph, what we can see is in the right paratracheal region, there's an opacity. It has sort of a smooth undulating course as it extends inferiorly. There's perhaps a little bit of tracheal deviation to the left. If we look at this mediastinum, there's actually a wave configuration to the left side of the heart where the anterior margin of the rib indents within. So here's the opacity that we see in the paratracheal region. And this was a chest x-ray that was read out as right upper lobe pneumonia, but this actually is a right aortic arch. And there are a number of conditions associated with an aortic arch. 25% of tetralogy of Fallot patients have a right-sided aortic arch. But if you were to take a look at other congenital cardiac conditions, namely truncus arteriosus, they have a much higher incidence of right-sided aortic arches. But tetralogy of Fallot is so much more common than almost every other congenital cardiac condition, so that when you see a right-sided aortic arch, you should be concerned about tetralogy of Fallot. So again, just notice the wave sign as a coincidental finding on this radiograph. Okay, so the next case is an 11-year-old, previously healthy girl. She bumped her left arm 1 month before and then noted a lump after that. She's been tender ever since. And 3 days prior to presentation, she also noticed that the lump on her shoulder had actually increased in size. So here's her radiographs. And I don't really have a question to perceive to this, but it's just, if you look at this case, you can see the subtle finding perhaps not too subtle, but the finding here is of this periosteal reaction that's there, but also there's extensive permeative bone destruction that you can see adjacent to this, as well as diffuse sclerosis involving the metaphysis extending into the proximal diaphysis of this left humerus, as you can see here. And you can also see the little bit of cortical destruction along the medial aspect. So the combination of these findings indicate an aggressive process. We can see and in that particular case it was due to an osteosarcoma. But you can also see these bony changes in multiple other areas in multiple other entities. This is a case of chronic osteomyelitis. You can see that the zone of provisional calcification involving the distal metaphysis of the right radius is gone, but there's also diffuse sclerosis in that area in this child. So part of the pearl of this one is to cast your eyes along the cortical margins and especially look at the metaphyseal regions. This is a very common site, A, for bone tumors, but B, a common site for infections because of the vascular looping that occurs in the metaphyseal area. Okay, so the next case is a 16-year-old girl. She has a 1-year vague history of intermittent mild chest pain, really no red flags, nothing really worrisome about her chest pain, no cardiac history, nothing of note. But her pain has worsened over the last 3 days, and she's known to have a pectus. So here's her chest radiographs. And is this normal? Does she have cardiomegaly? Does she have right middle lobe pneumonia? Or does she have a mediastinal mass? The most common response was that this is normal. So if we look at this radiograph, we've got loss of the heart border. There's apparent enlargement of the mediastinum. We can also see a reflection of the region of the sternum on the lateral radiograph. And one of the things to realize is that when you have a pectus deformity, it'll markedly decrease the AP diameter of the thorax, especially in the region of the sternum and vertebral body. And this results in a couple of things. One is that there's some rotation of the heart, and there's also some slight compression of structures. And all of this leads to a slight increase in size because we're not looking at the heart in its normal orientation. So this leads to apparent cardiomegaly. You might wonder why we got a CT, and the reason we got a CT was because this patient had actually been seen in a periphery. They thought the right heart border was gone. They thought the child had a mediastinal mass and CT'd them. And so one of the things to bear in mind is that, you know, if you can find a pectus abnormality, to recognize that two things are going to happen. One, the heart is going to appear falsely enlarged, and second, you're going to lose the right heart border, both of which are just normal phenomena in children with pectus deformities. So because of that, the findings might simulate a right middle lobe pneumonia, so don't call that. It'll simulate cardiomegaly, so don't call that. And also it may simulate a middle mediastinal mass, so don't call that either. Yes?
So just a question of what you guys do at your institution. Are you guys routinely doing CT for pre-op for Halloran disease in these cases, or do you have the diagnosis for that?
So these are patients where they're looking to put that bar in. So we actually are CTing them. You know, there's some good data to suggest that a plain radiograph can give you the Haller index with very similar results to doing a CT. But our pediatric surgeon who does them is very keen on getting that image. There's also another part where, we've had some interesting things happen. We had one kid who had that bar put in and it flipped in him with result in incredible pain. And the perception of our surgeon is that he wonders if, it wasn't appropriately placed, that if he had actually looked at the CT a little differently, he might have placed it a little differently. So I'm not sure how true that is, but I think that's kind of the driving force by why we CT. We definitely don't give them contrast. We just do a non-enhanced CT to look at those. What do you guys do here? Do you know what you're doing? Same? Yeah, okay. Fabulous. Okay, So let's look at another case. This is a 1-year-old, previously healthy, who had fever, irritability, and cough. Here's the radiographs. Does the child have pneumonia, a fracture? Is this normal, or do they have tuberculosis? Okay, let's see how we did. So the most common answer were fractures. Okay. So Dr. Lum many years ago taught me about blind spots. And this, if you look at this radiograph, beyond the margins of the chest, you can see in the circles callus formation involving multiple ribs. And, you know, on occasion, this is outside of our normal viewing pattern. We don't look, we're looking at chest x-ray, we look at the heart and lungs, we don't cast our eyes into the corners of the film. And so these are rib fractures. They're in very typical locations and for child abuse fractures. If you remember that when someone's shaking a child, they engulf the child's chest like this and shake them like this. And this results in fractures occurring at fulcrum points. Those points, most specifically where there is an articulation of the transverse process of the vertebra with the rib. And this leads to posterior rib fractures. This is really common. You can also see them further laterally, both in the posterior aspect of the ribs, but also in the lateral margins of the ribs, as well as at the costochondral junctions. So look at the bones, look at the corner of the films, and look for rib fractures. You know, it's interesting. Over time, as a radiologist, you sort of gestalt images. You just, instead of looking at, you know, the soft tissues, then the thorax, then you don't do that anymore. You just sort of scan straight down and look. But I always make a point of just casting my eyes one more time at the posterior aspect of the ribs. Child abuse comes in some very surprising manners to the hospital. You know, just recently we had a child come in who fell off. The story was they had fallen off a swing and came in with a massive bleeding subdural. And just as part of my routine, even though the child was 4 and even though the story was good, I just said, you know, the possibility of child abuse should be considered. They did a skeletal survey and there were multiple corner fractures. And so it'll surprise you on occasion what'll come in. Okay, so the next child is a 7-year-old with sickle cell anemia who had cough for a week, has fever and mild tachypnea. Our sickle cell population in Alberta is growing, so this is becoming more common. So this is the radiograph of the chest. And this child was seen by our emerge docs and basically sent home as being normal. So obviously it can't be normal, otherwise I wouldn't show it to you. So if we look at this chest x-ray, the thing to look at is to realize that there's a large portion of the lungs that are projected below the apex of the hemidiaphragms on the frontal radiographs. And that in children, at least 10% of pathology is only seen on a lateral radiograph. So again, one of my former mentors, Dr. Conway Dawn, taught us to cast our eyes down the vertebra and it should become more lucent as you came down. And here, if we look on this lateral radiograph, it's opaque just below those hemidiaphragms. And so this child got sent home and then came back shortly thereafter. And you can see how quickly this pneumonia had actually progressed in a 24-hour period of time. So one of the things that you should do, and I find it harder on a lateral, I find it a lot easier in a frontal projection, is to stare below the diaphragms and take a look. The lucency should be the same on both. So this was an example of pneumonia. So this is another example of a blind spot. And some of the other areas that are blind spots are the apices of the hemithoraces. It's very easy to miss pathology in those areas. And also the retrosternal area on a lateral radiograph, which is the area that constitutes the anterior mediastinum. So here, for instance, is a very subtle area of increased opacity at the apex of that left hemithorax. And this is a child who actually has a neuroblastoma. This child actually presented with Horner syndrome. Here's a retrosternal opacity. The frontal radiograph the findings are very subtle. It doesn't look that abnormal. But if you look at the lateral radiograph, there's an opacity filling the retrosternal area. And you'll be surprised to see what that is. If you look, that's what a normal retrosternal lucency should look like. It should be very similar in density to the lung posterior to the heart. And this is an ascending aortic aneurysm in a child, which you can only really perceive on the lateral radiograph. Okay, so our next case is a 16-month-old boy who was previously well, had bilious vomiting for a day, no fever, no diarrhea, had a history of minor head trauma, and because they couldn't really find a cause for his vomiting, they did a CT scan of his head as part of the workup, and that was normal, and then had these radiographs. So does this child have a bowel obstruction? Does this child have an ileus? Is there a bowel perforation, or is this normal? So this is a 16-month-old boy with bilious vomiting. So we've got a supine radiograph on the right and a prone radiograph, or sorry, supine radiograph on the left side of the screen and a prone radiograph on the right side of the screen. So vote now. What do you think? Okay, let's see how we did. Bowel obstruction, okay, is the most common response. So these are supine and prone radiographs, and on the bottom row I've showed you there's a different patient with a supine and a prone radiograph. And one of the things to realize is that the transverse colon is anterior, it's intraperitoneal, and the ascending and descending colon are posterior, they're retroperitoneal. So if you flip a child, if you go from supine to prone, you will change the distribution of gas within large bowel to other structures. So if you make the child prone, then suddenly the ascending and descending colon are more anterior and will fill with gas, and you'll get the reverse if you do the same. So the point is that if you do both of those views and sum them together in your head, the colon should totally fill with gas with both projections. And if we look at the top view, that doesn't happen. We've got gas we've got a paucity of gas in the region of the hepatic flexure. We have a piece of the ascending colon that does have gas, and there's very little gas in the region of the transverse colon, which should have filled on a supine radiograph. And this is a large bowel obstruction. And this is a large bowel obstruction due to an intussusception. So this is, you can see in the right upper quadrant on both films, there's a mass-like structure filling the hepatic flexure, and this is an intussusception. And if we hit play, this is an air reduction showing movement of that intussusception back from the transverse colon, and this will fill the ascending colon. I hope I picked one where I reduced it. I'm kind of curious now. Yeah, I know. And almost. So that looks terrible. So one of the difficulties you have is you can fill it all the way down to the ileocecal valve, and you might actually reduce it but not get reflux of gas into the terminal ileum. So we usually will ultrasound them right afterwards just to see if it's reduced. I hope this was one that reduced. I'll have to go back and check. Okay, so this next child is a 1-week-old who was a 36-week gestational age child who had abdominal distension and emesis and had a fever with poor oral intake. So this child, if you take a look at this one, do they have a bowel obstruction? Do they have an ileus? Do they have perforation, or is this normal? Okay, let's see how we did. So the most common response was perforation. So if we look at this supine radiograph, you can see a lucency projected over the liver, and you can see gas in the region of the falciform ligament. And this is a sign of a neonatal pneumoperitoneum. But in addition, You can also see a loop of small bowel where you can see gas on both sides of the wall, which is also known as Wriggler's sign, named after Leo Wriggler. And this is another sign of a neonatal pneumoperitoneum. And so one of the difficulties that we have in children up in the NICU is that they're sick, they don't want to be moved, no nurse will allow you to do very much, and so the technologists just have enough time and permission to do a supine radiograph of the abdomen. So it's important to know the signs of free intraperitoneal air in a neonatal abdomen. And typically, these are the two most common ones that we see. One is this lucency over the abdomen, which may or may not outline the falciform ligament. And secondly, Wriggler's sign, that detection. And if you're worried about it, one of the things that is best to do is to do a cross-table lateral view of the abdomen. Trying to get the child upright for 10 minutes is really not a realistic option. So these are the main signs. Look for a pneumoperitoneum. And they're very common. You know, you'll be doing chest radiographs and you'll see free air down in the abdomen. They all look the same. They have this vague lucency that extends over the hepatic margins. It's our experience that it's better just to do a cross-table lateral. It's easy to do. The kids are lying still. Some people suggest that if you're going to do an upright film to look for free intraperitoneal air, that you actually have to have the patient upright for 10 minutes so that enough gas will actually migrate up there to actually be seen. Look for a very, as in this case, this triangle sign of gas that's extraluminal that subtends the margins of bowel as an indicator of free intraperitoneal air. Okay. So the next case is a previously healthy 4-year-old boy. He's got a 2-week history of left leg pain, intermittent limp, able to continue activities, no history of a fever, a rash, or trauma. On today's exam, there's limited internal rotation of the left hip. These are the radiographs. So what do you think? Is this a child with slipped capital femoral epiphysis? Is this avascular necrosis? Is this a joint effusion? Is this juvenile arthritis? Or is this normal? So the most common correct answer was avascular necrosis. And here you can see on this blowed up margin a little subcortical lucency that you can see in the left femoral head. On the oblique frog leg view, you can actually see some slight fragmentation of that left capital femoral epiphysis. And that is avascular necrosis. Now, you can also, this is also known as leg Calvi-Perthes disease when it's idiopathic, and it can have a variety of manifestations. But primarily you'll see sclerosis, fragmentation, disruption of the articular surface. But one of the earliest signs is that subcortical lucency that you'll see on a frog leg view. Interestingly enough, there's a recent publication in the spirit of trying to decrease radiation that indicates that there probably is very little need for an AP radiograph of the pelvis if you're looking at a child with hip pain. That it's probably best just to do a frog leg view. You're going to pick up early signs of AVN better on that projection. You're going to see much better evidence of a slipped capital femoral epiphysis. And we haven't adopted that in our practice, but there is a feeling out there about the value of that frog legs view. Here's an example of slipped capital femoral epiphysis. You get what people have described as the melted ice cream head slipping off the femoral head. They're very tough to pick up on AP projections. But again, with a frog leg view, you can easily pick that up. So that is part of everybody's routine anyway, but it's important to look for those subtle signs of avascular necrosis. Okay. Excellent, you guys are doing great. So the next case is a 10-year-old boy who was previously well, has a history of asthma, and has been coughing and wheezing for 3 days. These are the radiographs that were done. Does this child have left upper lobe pneumonia, congestive heart failure, left upper lobe collapse, or left lower lobe pneumonia? Don, you might be interested that this child ended up in the neuro ICU. I'll tell you why shortly. Okay, are you guys good? All right. So the most common response was left upper lobe collapse. And this is a really classic picture of what left upper lobe collapse looks like. There's this veiled opacity that extends out to the periphery of the lung. You can see displacement of the fissure. And here's an example of somebody who's got fluid that shows you where the normal superior aspect of the left major fissure should be and where the minor fissure is. So you can see the displacement of the major fissure. And this is left upper lobe collapse. So the lateral radiograph is very helpful. That frontal radiograph is pretty diagnostic, but look for that fissural displacement. This child was interesting because they had left upper lobe. They had been eating an apple and choked on the apple. It then resulted in a piece of apple going down the left upper lobe. They ended up coding from a respiratory arrest and ended up with diffuse thalamic and cortical ischemia and is now palliative. So it, you know, signs of foreign body ingestion in children are things you should look for. You know, we can typically find, I've showed you guys a case this afternoon, but here's just another example of things that show up. Okay.
How old was that child?
10. Okay, so the next child is a 2-year-old boy who was previously healthy, had leg pain and a limp, no fever, but was otherwise well. So here are the choices. Is this chronic osteomyelitis with a sequestrum? Is this a malignant bone tumor? Is this a benign bone tumor? Or is this a healing fracture? Okay. So the most common response was benign bone tumor. And if we look at a blow-up of this area, we can see this diffuse sclerosis involving the cortical region as well as the diaphyseal region adjacent to an area of central lucency. And within this central lucency is a small sclerotic nidus. So this is incredibly typical for an osteoid osteoma, which this is. An osteoid osteoma is typically in children, we don't get to see that little lucent nidus with the little sclerotic area. That's very atypical. Typically, we have to use imaging with cross-sectional imaging, such as CT or MR, to look for it. More typically, we see what these two look like, which are either a focal area of cortical thickening, and that otherwise looks relatively benign, or we may see a small lucent area. And so when you see that, just in the back of your mind, just remember that there may possibly be a little nidus of an osteoid osteoma within this. Typically, you know, you'll have this history of, you know, pain that's at night, that's relieved with analgesics. But interestingly, most of our kids don't have that history. So not reading the textbooks as well as they should. Okay, we're just about done. I'm just going to show you a couple of interesting ones. This is, I've got 2 children who've had trauma. They've had lateral cervical spine x-rays taken, and these are the choices. So either A, they're both normal, 2, A is normal, B is abnormal, 3, A is abnormal, B is normal, or 4, both are abnormal. So I'll let you look at them, then we'll go back again to the scoring system, let you decide. All right, so let's look at these. So the upper pediatric C-spine has some very unique features in children. One is, if you have Atlanto-occipital dissociation as a child, you can survive. I mean, it's very uncommon for that to happen in adults. And so there are 3 measurements that people have looked at to try to diagnose Atlanto-occipital dissociation in children. One is the distance, the Atlanto-occipital distance, and I'll show you that. One is the Bayesian-Dens distance, and the third one is a ratio of the interspinous space between C1, C2, and C2, C3. And the other thing that's unique in children is something that requires the use of a measurement, which is known as the posterior cervical line, and this allows you to diagnose a condition known as pseudo-subluxation of C2 on C3. So let's look at that. So Atlanto-occipital dissociation is a devastating injury, but because of increased, and we're starting to see this more because there's better roadside medical management of pediatric trauma. And this injury primarily occurs in children, okay? This is a graphic example. This child's not going to survive, okay? And dissociation is basically due to instability of the atlanto-occipital junction, and it's caused by partial or complete disruption of the tectorial membrane, that rostral inflection of the posterior longitudinal ligament and the bilateral alar ligaments. So here are a couple of drawings. The tectorial membrane's been cut, and you can see it outlined in blue and on top and bottom, and it's a very thick membrane. It really does work well in keeping your head attached to your spine. And in addition, there's alar ligaments on either side that also aid in keeping these together. And there's been a number of papers looking at different plain film findings to try to diagnose atlanto-occipital dissociation. So one of them that was used is the Bézier-Dens distance. So you can measure that distance as outlined on this study, and if it's greater than 12 millimeters, this has a sensitivity of 100% and a specificity of 98%. With such high numbers, it's got to be wrong, but that's what's published. The other thing that people have used is looking at the ratio between C1, C2, and C2, C3. And if that ratio is greater than 2.5, it also has a high indicator of injury. So when you're looking at these radiographs, just cast your eyes at these in your mental checklist of clearing a cervical spine. The one I use, the one I really like, is to look at the articulation between the occipital condyles and the superior articulating facets of C1. There are 5 points. People have divided that articulation into 5 little areas and determined what normal measurements are. And if it's less than 4.5 millimeters, it's normal. And I like it because I can also measure it on CT, because I often get calls from the residents about, well, it looks a little wide, what do you think? And it's relatively easy to measure, and it's quite good. It also is a good finding on plain radiographs. You can see that actually quite well. And you can appreciate it if you realize that articulation is there. A plain radiograph on the left shows you that disruption. This is an abnormal one. And here's case A. If we look at the distance of this, you can see that there's widening along the posterior aspect of that atlanto-occipital articulation. And that distance actually measured up to 9 millimeters, so double what normal should look like. So case A is abnormal. It has atlanto-occipital dissociation. Case B, just for reference, that's normal. That shows just a normal distance of less than 3 millimeters. But what was concerning to people was the displacement of C2 on C3, right? That doesn't look quite right. And one of the things you have to realize in pediatrics is that the vertebral bodies have a very different configuration than what we see in adults. It can have quite a varied appearance. Vertebral bodies can be oval, they can have rounding of their upper corner, they can actually have wedging of the anterior superior margin of the C3 vertebra, or they can just be more normal and look rectangular. So we have 4 types of these vertebral bodies of C3. And a graduate from our medical school in Alberta came up with what's called the posterior cervical line, Leonard Swischuk. Those of you who do peds radiology will be very familiar with him. And what he found was that in cases where C2 is displaced or appears displaced relative to C3, if you draw a line between the spinal laminar junction of C1 and C3, it should pass through the spinal laminar junction of C2. And so we have 3 possibilities. One, if they're lined up, well, there's no use for the measurement, it's not applicable. But in cases where C2 is anterior to C3, if the posterior cervical line lines up between C1, C2, and C3, it's normal. This is pseudo-subluxation of C2 on C3, it's a normal finding. If it doesn't line up, then there's usually a fracture present. So it's a good line to be aware of. It'll help you sort out a lot of calls that you may get from pediatricians, as well as questions that you may see when you get radiographs of the cervical spine. So in patient B, there is normal alignment of C2 with the posterior cervical line, and this is just pseudo-subluxation of C2 on C3. So we have these two cases. Case A is Atlanto-occipital dissociation, and the second one is normal. It's just pseudo-subluxation of C2 on C3. So a couple of unique features for pediatric spines, things you probably should look at. We are now over time. I hope you enjoyed those cases. There's some things that are kind of unique to pediatrics. They primarily deal with plain radiographs, and they're things that you're going to see in everyday practice. There are a lot of things that if you see, you'll probably be able to sort what they are out on plain radiographs and obviate the need for further cross-sectional imaging. And if nothing else, it'll make you sleep better at night if you can feel confident in calling what you see, what you see. Just in closing, I'd just like to thank everybody. I'd like to thank Roya for inviting me. I'd like to thank Andrea for the hospitality, and I really enjoy coming back to London anytime. It's a great honor for me, and I really enjoy coming here. I feel I owe a great deal of my success to the people that are in this room. So thank you very much.